This conference will now be recorded.
And like I said, the patient assessment is used to some degree in every patient encounter that you're going to have. So there's 5 parts of your assessment: your scene size up, your primary assessment, your history taking, your secondary assessment, and your reassessment. And the order in which the steps are performed depends on the patient's condition and the environment in which the patient is found. It might be necessary to change the order of some of the steps after the scene size up based on your findings. And it's rare that one sign or symptom would show you the patient's entire status or their entire underlying problem. Um, Something important to differentiate is the difference between a symptom and a sign. A symptom is a subjective condition that the patient feels and tells you about, where a sign is an objective condition that you can observe. So, for example, the patient may have a headache. A headache would be considered a symptom because you can't see it, but the patient can tell you about it. Whereas shortness of breath would be a sign because you can see that they're struggling to breathe. It's not just something they're going to tell you about. That's an important distinction to remember. Your scene size up. Your evaluation of the conditions in which you're going to be operating. You need to maintain situational awareness. And sizing up the scene combines an understanding of the situation and the conditions prior to responding, the dispatcher's basic information, and your observations of the scene. Some of the issues range from minor difficulties to major dangers. You shouldn't enter until the scene is safe for you and your team. Typically, the way you enter an area is also the way you should leave. And if you're on the road, you should have a vest on. Another consideration would be difficult terrain, traffic safety problems, and any environmental conditions you might run into, whether that be extreme heat, extreme cold, anything like that. If it's appropriate to do so, you should help protect the bystanders from becoming additional patients. Um, Obviously, you shouldn't necessarily put yourself or your primary patient in jeopardy to do that, but if you're able to do so safely, help protect the bystanders. Some of the hazards: extreme weather conditions, right up to the threat of physical violence. An emergency scene is a dynamically changing environment, meaning at any second, you could go from having a safe scene to having an unsafe scene. You've got to keep your head on a swivel and you've got to be prepared for that. You've got to be prepared to make changes if you need to. Determining the mechanism of injury or the nature of the illness. Uh, your calls can be categorized as medical conditions, traumatic injuries, or both. When we talk about mechanism of injury, we're looking for the type or the amount of force, how long that force was applied, and where it was applied to the body. Blunt trauma would be when the force occurs over a broad area. Typically, the skin is not broken, and the tissues and organs below the area of impact might be damaged. Penetrating trauma. The force of the injury occurs at a small point of contact between the skin and the object. Um, this is where you're going to see the open wound, and you've got the high potential for an infection there. So for the trauma patient, we're looking at the mechanism of injury. For the medical patient, we're looking for the nature of their illness. So there are similarities between both, you know, how they got injured versus how they became sick, the signs and symptoms of their injury versus their illness. A lot of your questioning is the same between the two. You're going to want to talk to the patient, family, or bystanders to figure out kind of what's going on else there. And again, you would do that with both medical and trauma patients. You'd want to talk with the patients, families, and bystanders. You can use your senses to check for clues. See something, smell something, hear something. That boils back down to the scene safety concerns as well. Constantly watching the environment around you. Be aware of scenes with more than one patient with similar signs or symptoms. For example, carbon monoxide poisoning. Carbon monoxide poisoning, the signs and symptoms you're going to see are flu-like symptoms. So if you respond somewhere and you've got 3 or 4 patients that are all exhibiting the same symptoms, you should be asking why. Why are these patients all sick? What could be going on here? And are you putting yourself and the other responders in danger by entering a scene like that? So your mechanism of injury and your nature of illness is going to be how you determine what treatment pathway you're going to take with your patient. Um, you might immediately categorize a patient as either trauma or medical, and come to find out it's the complete opposite. Just because the patient has a puddle of blood under them doesn't necessarily mean they're having a traumatic issue. There could be a medical issue there as well. Don't be too quick to judge. Make sure you do a full assessment before you make that determination. Standard precautions. So we preach this all the time, and ever since COVID hit, it's been an even bigger thing. You should always be wearing your personal protective equipment. And what you wear is going to depend on what you're doing in the field. You may not be wearing an eye shield and a gown for every patient you encounter, but there are some scenes where that makes sense. So standard precautions have been recommended for use in dealing with objects, blood, bodily fluids, and other potential exposure risks for communicable diseases. However, most states are still requiring standard precautions for every patient encounter. New Hampshire is still one of those states. You are still required to wear a mask and gloves for every patient you encounter. When you're stepping out of the vehicle, you should have already taken those precautions. So when you're getting out of the truck, you should have your gloves on, you should have your mask on, and you should consider protection. Don't walk into the environment and then put that stuff on. Walk up to the scene ready to work, just like you would as on the fire side of things. You don't wait to put your air pack on until you get into the building. You get off the truck ready to go. Your number of patients. So when you're sizing up the scene, this is one of the things you're looking for. Do you have more than one patient? Even if you're only dispatched for one patient, there's always potential for more than one patient to be present. And additional resources. So if you have more than one patient, you're probably going to need to request more help. Don't ever be afraid to request additional resources. And then obviously the incident command system should come into play. Um, Multiple patient incidents, you're going to begin triage. So triage is the process of sorting patients based on the severity of their condition. Um, for those of you that aren't familiar with the triage process, all of our ambulances carry triage tags. The tags color code our patients based on their condition. Um, Black being deceased, green being minor, yellow being moderate, and red being immediate life threats. So in a situation where you have many patients, you can't focus on just one patient because you have so many. So in a triage system, we're quick to write off patients. And unfortunately, that means that if a patient's not breathing, we are not going to stand there and focus our efforts on that one patient. We're going to have to black tag them and move on to the next. A patient that is still breathing but is on the verge of ineffective breathing is going to see a red tag. A patient that's what we call walking wounded, who is able to ambulate on their own and doesn't have any major life threats, they're going to get a green tag. And like we talked about, some situations may require more ambulances and specialized resources, whether that be a hazmat team or, you know, you may go for the flu-like symptoms call and you get there just as an ambulance and you think there might be something more going on there. You think there might be a carbon monoxide incident going on. That specialized resource might just be getting the fire department there. Some of the other specialized resources we deal with: advanced life support or ALS, air medical support, calling a helicopter, fire departments, and some of the different things the fire departments can do: high angle rescue, hazardous materials, water rescue, and then law enforcement. So when you determine if you're going to need the additional resources, you should ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And do we have the resources to respond to their conditions? The primary assessment. So this is going to begin when you greet your patient. So anytime you approach a patient, you should introduce yourself. And by doing that, you can, a lot of times you can get your sick, not sick evaluation really fast. If you walk in and you greet your patient and say, "Hi, I'm GT from the ambulance. What's going on today?" And they look at you and start telling you a story, a lot of times you can start down the path of not sick. When they look at you struggling to breathe and can only get a word or two out at a time, now you know immediate life threats. We've got to go to work here. The goal is to identify and initiate treatment of immediate or potential life threats. Like I said, you see they're struggling to breathe, or maybe it's a trauma scene and you see that they're hemorrhaging, they're losing a lot of blood. Whatever the case, immediate life threats you're going to address right then and there on your primary assessment. Um, Physically examine your patient. We have to touch our patients, but we should always be asking permission to touch our patients before we do it. Some of the things we're going to assess: LOC, level of consciousness. Are they awake? Do they answer you? Um, do they require painful stimuli to respond to you? Do you need to do a sternum rub? If you physically touch them, do they respond to you, or are they unresponsive? The ABCs: airway, breathing, and circulation. So without any of those things, you don't have a living patient. They have to have an airway, they have to be breathing, and they have to be circulating blood. From there, from your general or your primary assessment, you can form a general impression of the patient. This is the sick, not sick determination that I was speaking about. It determines the priority of your care. It's the first part of your primary assessment. And while you're doing this, you're going to make a note of the person's age, their sex, and their race, their level of distress, and their overall appearance. So, why are some of those things important? When we talk about a patient's age, is there a difference with a patient having chest pain that's 12 years old versus a patient that's 50 years old? There could be. Male versus female. Some of their conditions are going to present differently. Men and women have different presentations for cardiac symptoms. Their race. Are there certain disease processes that might affect a race differently? There absolutely are. Their level of distress, that's something you can determine right away. Like I said, you can tell if they're in distress. Their overall appearance. A lot of times, just by looking at someone, you can tell if they're truly sick. You want to note the patient's position. Where does that come into play? So if you walk in and you see the patient lean forward with their elbows on their knees, struggling to breathe, there's a lot of signs there that that patient is truly struggling to breathe. If they're sitting back in a chair watching the game when you show up, that might be a little different for you. Maybe they're not as sick of a patient. You should always avoid standing over the patient. Always try to stand next to them. Bring yourself to the same level. Address the patient by their name. When you introduce yourself, that's one of the first things you should ask. What is your name? Try to call them by their name. It makes them feel more comfortable. It makes them open up to you a little bit more. Introduce yourself. Introduce your partner. Ask them about their chief complaint. And if you identify any life threats, address them immediately. And this is the sick, not sick. Determine if the patient's condition is stable, stable but potentially unstable, or unstable. So now we'll talk about some of the life threats. Uncontrolled bleeding. That should take priority over any other assessment. We don't care what their last oral intake was if they're bleeding out. Assess their level of consciousness. It can tell you a lot about their neurologic and physiologic status. Whether they're confused, whether they're not acting appropriately, whether they're saying things that don't make sense. All of those things you need to be looking for. And the only way you're going to really be able to assess that is by talking to them. Assessment of an unconscious patient focuses on the ABCs, the airway, breathing, and circulation. Sustained unconsciousness should warn you of a critical respiratory, circulatory, or central nervous system problem. People don't just go unconscious. There's a reason that they're unconscious. And the longer they're unconscious, the worse it can be. Conscious with an altered level of consciousness may be due to inadequate perfusion. It could also be caused by medications, drugs, alcohol, or poisoning. To assess for responsiveness, we use the mnemonic AVPU. This is something that you want to write down. This is something you want to remember. This is something you'll use for every patient you talk to in the future. So the AVPU, awake and alert, responsive to verbal stimuli, responsive to pain, or unresponsive. You pick one of these for each patient. Which one are they? If they're awake and alert, that's the patient that greets you as you walk in. They're able to talk to you freely. Responsive to verbal stimuli is a patient who may be asleep. And when you speak to them, when you say their name or when you announce that you're coming into the room, they wake up, they look at you, they talk to you. Responsive to pain, that's when you touch them, that's when you do a sternum rub and you get a response out of them. And unresponsive is when you get no response. Testing responsiveness with painful stimuli. Um, you can gently but firmly pinch their earlobe. You can press on the bone above their eye, and you can gently but firmly pinch the muscles of the neck. Those are some different ways that you can, if your patient's not responding to you on their own, they're not responding when you speak to them, these are some ways you can kind of additionally try. We do have patients that are deaf. Maybe they're asleep and they don't even know you're there. So the patient's orientation, it's going to tell you a lot about their mental status. This is, you're evaluating their ability to remember person, place, time, and event. So this is where you need to ask the questions. Do you know where you are right now? Do you know what day it is? Do you know who the president is? We ask those silly questions all the time, and patients give us funny eyes when we ask them, "Do you know who the president is?" But it tells us that they know what's going on. And you will have patients where you ask, do you know who the president is? And they say Ronald Reagan. And they're not trying to mess with you. They're not in their right frame of mind. They're saying things that don't make sense. You can take that a step further. It doesn't have to be who's the president. Is their spouse in the room with them? Ask what their spouse's name is. Is their child in the room? Ask what their child's name is. There's a lot of different questions you can ask to determine if they're oriented, if they're thinking correctly. So you want to evaluate their long-term memory, which is, like we said, who's the president, your spouse's name, your child's name, their immediate term memory. Give them a phrase to remember. Say a word. It doesn't matter. The word soap. I'm going to ask you again to repeat this word. I want you to remember the word soap. Wait a few minutes and see if they remember it. So we would consider any deviation from alert and oriented to person, place, time, and event to be considered altered mental status. However, you have to consider the patient's normal baseline. If you're dealing with an elderly person who may have some dementia, Alzheimer's, any of those things, you have to consider that. And that's where you have to rely on spouses, caregivers, children, anybody who may be around them who can kind of tell you, are they acting the way they normally would, or is this different for them? And that's going to tell you if they're altered or if they're not. If you don't know, if you can't tell, if there's no one there to tell you, you need to assume they're altered until you can prove otherwise. Identify and treat the life threats. So some of the conditions that we consider life threats, they can cause sudden death and airway obstruction, choking on something, for example. Respiratory failure, they stop breathing. Respiratory arrest, shock, severe bleeding, and cardiac arrest. All of those things will lead to cardiac arrest eventually, if not corrected. In most cases, you're going to begin with airway. So you're going to check to verify that their airway is clear and open. There's a couple different ways you can do that. We have the jaw thrust and we have the head tilt chin lift. Those are things that we'll go over once we're in the practical sessions. We'll show you how to do those things, but that allows you to open the patient's airway. You can tell, is there an obstruction? Are they making gurgling or snoring noises? That might indicate that there's something in the airway. Breathing. Are they breathing? And if they are they breathing adequately? We have something called agonal respirations where the patient is kind of making those rattling, snoring, end of life sounds. That is not considered breathing adequately. That is an immediate life threat that we would want to address right away. And the patient's circulation. We're looking for bleeding? Do they have any major bleeds? Do they have a pulse? And what is their skin like? Are they cool and clammy? Are they sweaty? Are they hot? Are they profusely sweating? All of those things can be indicators of other life threats going on. In some cases, it may be appropriate to address threats to circulation first. That would be the scenario where you walk in and you can tell that they're obviously bleeding out from a wound. Address that circulation first. In that scenario, if you can tell that they're bleeding out, it doesn't matter if their airway's clear or not if there's no blood left to circulate. You have to use your judgment on that, and that's where you have to be looking at the big picture and you have to assess your patient from head to toe. Assessing the airway. As you move through your primary assessment, stay alert for signs of airway obstruction. Like I said, look, listen, and feel. I mean, feel the air coming in and out. Listen to their lung sounds, and look in their mouth. Ensure their airway is remaining open, which we call patent, and adequate. Responsive patients. So these are patients who are talking or crying. We know that they have an open airway because they're able to talk or cry. Watch and listen to how they speak. If their speech sounds abnormal, if it sounds like they're gasping, if you hear whistling noises or something like that, something that might indicate that there's something in their airway, but they're still able to speak, you might still have a problem there, so you need to be alert for that. If you identify an airway problem, stop your assessment and work to clear their airway. Unresponsive patients. So if a patient's unresponsive, immediately assess their airway. Use the jaw thrust technique or the head tilt chin lift technique when necessary. So again, we'll go over those techniques in the practical sessions, but the jaw thrust is something we would use if we suspected a spinal injury because it doesn't move the spine as much, whereas the head tilt chin lift actually moves their spine. Relaxation of the tongue muscles is a cause of airway obstruction, especially in children. When you look at a child, their airways are very small. Imagine a straw. Their tongues are very big. It doesn't take much for their tongue to cover their airway and block their airway. Signs of obstruction in an unconscious patient. Obvious trauma, blood, or an obstruction. That's where you're looking. Look in their airway and see what you can see. Noisy breathing, snoring, bubbling, gurgling, crowing, abnormal sounds. Anything that doesn't sound like normal breathing should be a concern. Extremely shallow or absent breathing. That's that agonal breathing we're talking about. It's not adequate breathing. Assessing their breathing. If their airway is not open, if their airway is not patent, they're not going to be breathing adequately. So you need to ask yourself, are they breathing? Is it adequate? And is the patient hypoxic? Hypoxic meaning lacking oxygen. Consider providing positive pressure ventilations with an airway adjunct when the respirations exceed 28 breaths per minute or the respirations are fewer than 8 breaths per minute. If they're breathing less than 8 times a minute, they're not breathing adequately. They're not moving enough air. If they're breathing too fast, 28 times a minute or more, they're not having the gas exchange in their lungs that they need. The air's coming in and out, but it's coming in and out so fast they're not actually exchanging the gases. And without that, the quality of their breathing is not adequate. The goal for oxygenation for most patients is going to be 94 to 99%. Depending on other conditions that they might have, emphysema, CHF, COPD, some of those patients, their numbers are going to be lower. Most of those patients know that their numbers run low and they can tell you that their numbers are lower. Our goal is typically on most patients 94 to 99. That does vary patient to patient. Observe how much effort is required for the patient to breathe. So we're looking for things like retractions, use of the accessory muscles. So you're going to need to look at the patient. You're going to need to see their chest. You're going to need to see, do you see muscles flexing when they're trying to breathe? Does it look like they're working to move that air? Nasal flaring. Do you see their nose flaring when they're trying to breathe? 2 to 3 word dyspnea. This is when the patient can only get a word or two out in between their breaths because they're struggling to breathe and they just can't get it out. The tripod position, that was what I was talking about earlier with the elbows being on their knees and they're leaning forward. They're trying to make their chest bigger. They're trying to allow their lungs to inflate more so they can move more air. The sniffing position, that's something you see with children where their head will be back and their nose is in the air like they're sniffing the air. They're trying to move more air into their body. And then labored breathing. You can tell when somebody is labored in breathing. We all have experienced this even though we may not be sick. You get out of breath, you become short of breath, and think about yourself getting out of breath and what that would look like to somebody. Those are the things you're looking for. Respiratory distress is when we see that increased work of breathing, the increased effort, and the increased rate. Again, that's imagine yourself, you just ran up a flight of stairs and you're working to breathe after that. You're breathing a little heavier than you normally would. Respiratory failure. So this is when your respiratory system is just that, failing. The blood is inadequately oxygenated, or the ventilation is inadequate to meet the oxygen demands of the body. So, like I was just saying, they're breathing so fast, they're not getting that gas exchange in the lungs. Although they might be breathing plenty of times per minute, they're not actually getting the good air movement inside the body. The ultimate result of respiratory failure, if it's not corrected, eventually it's going to be cardiac arrest. Circulation. So, circulation has a lot of different components to it. The mental status plays into that. Their pulse plays into that. And their skin condition plays into that. The pulse is a pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. You feel the pulse. If you can't feel a pulse in an unresponsive patient, start CPR. If you don't feel a pulse, start CPR. The skin condition. Evaluate their skin color. Is it gray? Is it yellow? Is it red? What does it look based on their norm? Evaluate their skin temperature, hot or cold. The skin moisture. Are they profusely sweating? Are they clammy? Capillary refill. So if you all take your hand and you push on your hand, see it go white and then the color come back, that's capillary refill. In a normal person, that should happen almost instantaneous. If that's extremely delayed and you push on your hand, you see it turn white and you let go and the color takes a while to return, that's a bad sign. A normally functioning circulatory system perfuses the skin with oxygenated blood. If your capillary refill is delayed, that's a sign that you're not perfusing with oxygenated blood fast enough. Skin color, again, it's determined by the blood circulating through the vessels and the amount of pigment present in the skin. Poor circulation is going to cause the skin to appear pale, white, ashen, or gray. When the blood is not properly saturated with oxygen, it appears blue. You're going to see that blue cyanotic color if the patient's not perfusing appropriately. In the photo there, you can see the baby with the blue around its mouth and nose. That's called cyanosis, and that's a sign that they're not breathing adequately. Skin temperature. Normal skin is going to be warm to the touch. Not hot, warm. If they're hot, cool, cold, or clammy, that's abnormal. That should be a sign that something else is going on. Skin moisture. Normally, your skin should be dry. Wet, moist, or excessively dry and hot all suggest different problems. And the capillary refill. You're assessing the ability of the circulatory system to restore blood to the capillary system. Um, Typically, you do that on their fingernail. You can press on the fingernail, and just like we did with the hand, you can see the color go away and come back. So the normal time for that refill is within 2 seconds. Anything longer than that should be a cause for concern. And again, major bleeding is part of your circulation. Before you're addressing airway or breathing concerns, if you see major bleeding, fix it. Bleeding from a large vein is a steady flow of blood. not spurting, it's just a steady flow. Bleeding from an artery is your spurting flow of blood. Controlling external bleeding can be simple. You should start by applying direct pressure. If the direct pressure is not working, move to a tourniquet. Your rapid exam. So, your rapid exam is meant to be just that. This is not your in depth exam. This is the quick down and dirty. And you're identifying any injuries that need to be managed or protected before you transport the patient. It shouldn't take any more than 60 to 90 seconds. And like I said, it's not your in-depth focused physical exam. This is the quick down and dirty. Determine priority of care and transport. So for every patient, you should be determining this. Are they critical and do they need to move now? Or do we have the time to continue assessing them and continue treating them before we move them? Your primary assessment is going to help you determine what their priority is. High priority patients, for example, a patient that's unresponsive, a patient having difficulty breathing, a patient with uncontrolled bleeding. All of those things are high priority patients that don't have time to wait. They need to get to definitive care. Patients with altered level of consciousness, patients with severe chest pain, patients with pale skin or other signs of poor perfusion, a complicated childbirth, severe pain in any area of the body. Those we shouldn't be sitting around with. We need to get them moving. The golden hour is something we talk about with trauma patients. It's the time from their injury to the time they make it to definitive care. You want that to happen within an hour. You want them in a trauma center within an hour. So here's a little photograph to kind of show what we're talking about here. So they're giving us 30 minutes to stabilize them, provide initial stabilization. 20 minutes for discovery of the incident and the activation of EMS. So that's before we get there. 10 minutes should be spent assessing, intervening, packaging, and getting them on the road. 10 minutes on scene time, and then 30 minutes to get to the hospital from there. In some places, that's just not possible, and that's where things like helicopters come into play. Your transport decision, it should be made based on their condition, the availability of care, the distance of transport, and your local protocols. Some states have protocols that dictate, for example, if you have a car accident with a patient trapped and it's going to be more than an hour to get that patient out, you need to have a helicopter coming because of that golden hour. Availability of advanced care. If you have an obvious trauma patient, it might make more sense for you to put them in the ambulance and take them to a trauma center versus just taking them to a local hospital who's not going to be able to treat them. These are things that you have to determine based on their status and in conjunction with medical control. History taking. You have to be a good historian in this job, and in order to do this successfully, you have to be comfortable talking to the patient or family or whatever the case. Your history taking is going to provide detail about the chief complaint and their signs and symptoms. And it's going to include demographic information such as the date of the incident, the patient's age, gender, race, their past medical history, and their current health status. You're going to investigate the chief complaint. So, like we talked about before, make your introductions, make the patient feel comfortable, and get their permission to treat them. And that's as simple as introducing yourself. I'm here from the ambulance. I'm here to help you. Is it okay if I touch you to assess your pulse and your blood pressure? Is it okay if I put this blood pressure cuff on your arm? Is it okay if I look at this? Is it okay if I touch this? Tell them what you're doing. It makes them feel more comfortable. Ask simple and direct questions. There are some patients who are only going to answer what you ask. There are other patients where you're going to ask them a simple question and you're going to get a half-hour long story about their entire life. Simple, direct questions. So they'll give you a simple and direct answer. So, a respect thing here. You should refer to the patient as Mr., Ms., or Mrs. with their last name. They might tell you, no, you can call me by my first name, it's okay. But start out being professional, calling them by Mr., Ms., or Mrs. Your question should be open ended. Don't lead them down the path. Give them the opportunity to say what they're thinking or what they're feeling. Don't lead them. Make your questions open ended. If your patient's unresponsive, it might be hard to get a history from them. But this is where you can become kind of a detective. Is there anybody else there? Are the people that there, do they know them? Do they know the person? Do they know anything about them? Um, Somebody may have witnessed what happened. Bystanders might know something about them. They might have medical alert jewelry. So patients with things like diabetes or seizure disorders will occasionally wear a necklace or a bracelet that says they're diabetic or says they have some kind of a seizure disorder, whatever the case. One of the things that's growing even bigger nowadays is tattoos. Instead of getting a bracelet or wearing a necklace, they'll actually get a tattoo on their body. Um, Another thing that you can look at is people have their medical ID on their phone. You might be able to grab their cell phone and open up their medical ID, and it would give you their medical history. Um, Other patient medical history documentation. People that are frequently in the hospital and frequently going to the doctors, you walk into their house and the first thing you see on their kitchen table is their discharge paperwork from the last time they were at the hospital or the doctors. That might tell you a story. Uh, Look by the sink. Are there a bunch of pill bottles there with the patient's name on them? That would tell you something too. Another mnemonic for you, OPQRST. This is what we use to assess the patient's symptoms. This is another one that you will use for every one of your patients. Write it down and know it, understand it. Onset. When did it start? Provocation. Anything make it better or worse? Does anything change it? Quality. What does it feel like? Is it sharp? Is it dull? Region or radiation. Does it move anywhere? Does the pain move into your arm or into your shoulder, into your hands, into your legs? The severity. Rate your pain on a scale of 1 to 10. And the timing. When did it start? Identify pertinent negatives. So, pertinent negatives are things that you would ask. So, for example, if a patient's having chest pain, you'd want to ask them, do you also have difficulty breathing? That's a pertinent negative. It's pertinent to the patient, so you'd want to ask it to verify that it's not going on. The definition of a pertinent negative is a negative finding that warrants no care or intervention. Another one, sample. I'm going to use this for every patient too. Write it down, know it. Signs and symptoms. Allergies. Does the patient have any allergies to any medications? Medications. What do they take for medications every day? Pertinent past medical history. And this is another one of those where some patients are going to tell you they have no medical history, even though they have all kinds of scars all over their body, they have a pacemaker implanted and everything else, and they'll tell you they have no medical history. Or you're going to get the person that's going to tell you about every time they've had stitches and every tooth they've had removed. Ask for pertinent medical history. The last oral intake. That can be important depending on what the patient has going on. What's the last thing they eat and when did they eat it? And events leading up to the injury or illness. What were they doing when it started? Critical thinking while you're doing your assessment. You're gathering information by seeking facts. You're evaluating the information to see what it all means when you put it together. And once you put all that information together, you're going to come up with your scene management plan and your patient care plan. Sensitive topics. Unfortunately, this is something we deal with, and we deal with it a lot. And you've got to be comfortable talking to patients about things that are sensitive. So, alcohol and drugs. Some of the signs might be hidden, disguised, confusing. The patient might deny it. The history that you've gathered from them might not be reliable. Don't ever judge the patient. Be professional. Ask the question. And one of the things that we say all the time, we're not the police. We don't care if you've done drugs. We need to know so that we can treat you and take care of you. A lot of times they're still not going to be truthful with you. Unfortunately, that's the nature of the beast. Do the best you can to gather the information. Look at your surroundings. Be aware of the things going on around you. Be aware of what's around the patient. Don't judge them, but be aware of what's going on around them. Physical abuse or violence. This one's huge. And as EMS providers, we are mandated reporters for things like this. You are to report all physical abuse or domestic violence to the appropriate authorities. If the police aren't there, you need to call them. It's okay to take the patient to the hospital, but the police need to be notified. Follow your local protocols. Don't make accusations. Just involve law enforcement. Your job at that point is not to help the patient through whatever they're dealing with or whatever happened to them. Your job is to treat them, keep them safe, and get them to the hospital. The police will take the rest of it. Sexual history. Females of childbearing age with lower abdominal pain are always pregnant until proven otherwise. They can tell you that they're not sexually active. They can tell you there's no chance I'm pregnant. I took a test. There's no way. It couldn't have happened. We used protection. They are pregnant until proven otherwise. You have to treat them that way. Ask them about their last menstrual period. For us guys, this can be an awkward conversation to have with someone, but we have to do it. It's critical to their care. Inquire about urinary symptoms with male patients. When it's appropriate, ask about the potential for sexually transmitted diseases. Again, it's a sensitive topic, but it could make a big difference in our care with these patients. It kind of plays into this today too as well. Transgendered individuals, depending on where they are in the process, they may appear to you as a male, they may identify as a male, but they may still have the ability to carry a child. Don't forget those things, and those are an important part of your assessment. And you've got to be sensitive to the people that are going through that. Again, no judgment. We're here to treat them. We're here to keep them safe and take care of them. But we've got to discover the facts that we need to treat them. Silence. You will deal with patients that don't want to talk, especially in children. You have to be patient with them. Try and give them close-ended questions that are just your yes or no answers. Consider whether the silence is a clue to their chief complaint. Consider their surroundings. Consider what's going on around them, what's going on with them. Consider the different reasons that they may not be speaking to you. Overly talkative. Excessive caffeine consumption. They might be nervous. They may have had some kind of drugs, such as cocaine, crack, methamphetamines. They might have an underlying psychological issue. If they're overly talkative, that could be a clue. May not always be, but it could be. Multiple symptoms. just like you would when you're triaging a trauma scene. You will prioritize their complaints. They may have 10 complaints. You have to prioritize them. Start with the most serious and end with the least serious. Anxiety. Almost all of our patients are going to be anxious. Whatever they've called 911 for, to them, they're having the worst day of their life right there. They're going to be anxious. And that's where coming in confidently, making them feel comfortable, can really make the difference with them. Patients that are having a lot of anxiety might show signs of psychological shock. Pallor, diaphoresis, shortness of breath, numbness in the hands and feet, and dizziness or lightheadedness, and even loss of consciousness. You got to rule out anxiety before you look down another room. Anxiety can also be an early indicator of things like low blood sugar, shock, and hypoxia or lack of oxygen. Anger and hostility. Family, friends, bystanders, patients, they might direct their anger and rage towards you. You've got to be calm. You've got to be reassuring. You've got to be gentle. Don't challenge them. Don't stand up to them. Again, whatever they've called you for, they're experiencing the worst day of their lives. You have to remember that going into it. They're going to be amped up. They're going to be quick to become angry or hostile. But if it gets to the point where the scene's not safe, it's time to back off. You're not going to do yourself or your patients any good if you get injured. If the scene's not safe, back out. Call for help. Intoxication. Do not put an intoxicated patient in a position where they feel threatened. Potential for violence and physical confrontation is high, and alcohol will dull a patient's senses. Crying. A patient who's crying might be sad, they might be in pain, or they might be emotionally overwhelmed. Be calm, reassure them, be confident. Use a soft voice with them. Depression, one of the leading causes of disability worldwide. Some of the symptoms: sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, and a decreased energy level. Be a good listener. Ask them appropriate questions. Listen to them talk. Sometimes the best thing you can do for these patients is let them talk. If they don't want to talk, sometimes the best thing you can do is let them not talk. You've got to read the patient, read the situation, and determine what you think is the best way to keep them comfortable. Confusing behavior or history. So we talked about this a little bit earlier. Conditions like hypoxia, stroke, diabetes, trauma, medications, and drugs can alter their explanation of the events. Older patients might have dementia, delirium, or Alzheimer's. Sometimes the history they're giving you just doesn't make sense. You've got to do your best to weed through that and figure out exactly what's going on. And like we talked about earlier, use the things around you to determine that. Medications, for example, discharge paperwork if they might leave it around. Is there a family member that you can call if they're not on scene? Limited cognitive abilities. Keep your questions simple. Don't use medical terms. Don't try to confuse people. Be alert for partial answers and keep asking clarifying questions. Rely on the presence of family, caregivers, and friends to help with the answers. Cultural challenges. Um, don't use medical language. Um, Patients may prefer to speak with a healthcare provider of the same gender. Um, Depending on their culture, that might be something they're looking for. If you can adapt to that, that's great. If you can't, you can't. Medical control could be another option in this scenario. Gain assistance from patients' friends or family members. and enlist the help of healthcare providers from the same cultural background if you can. If you happen to know that there's somebody with the same background at one of the hospitals, try and make contact with them and see if they'd be able to help you through it. Language barriers. Find an interpreter if it's possible to do so. If it's not, figure out if they even understand who you are and why you're there. Keep your questions straightforward and brief. You can use hand gestures, um, and just be aware of language diversity in your community. Everybody's community has different trends and different cultural backgrounds, so be aware of what's around you in the area you work. Um, as far as interpreters, I think Tyler covered this in one of the presentations before. 911 has interpreter services. Don't hesitate to call 911 even once you're there with the patient and tell them you need help from an interpreter. Um, a lot of times the hospitals have access to that as well. If 911's not working out for you, try and get in touch with the hospital. Patients with hearing problems. You're going to have plenty of these. Ask questions slowly and clearly. Um, you could use a stethoscope as a hearing aid. Um, learn simple sign language that can help you with communication. And then you can always use a pencil and paper. Even more importantly with these, don't yell at them. Don't immediately start yelling just because the patient's older. Adjust your tone as needed for them to understand you. And then visual impairments. Identify yourself verbally when you enter the scene. If you've moved anything, put it back. Don't move a chair and then have them trip over it. Explain to the patient what's happening in each step of the assessment of vital signs. And really, yes, it's important with a patient with visual impairments, but you should do that with every patient. Tell them what you're doing, explain what's going on. All right, before we start secondary assessment, let's take 5.
This conference will now be recorded.
All right, let's move into secondary assessment. So if the patient is in a stable condition and has an isolated complaint, you may choose to perform your secondary assessment at the scene. If the secondary assessment is not performed at the scene, it should be performed in the ambulance en route to the hospital. However, there will be situations where you may not have time to perform the secondary assessment. You may have to continue to manage life threats identified during the primary assessment while you're en route to the hospital. The purpose is to perform a systematic physical exam of the patient, which is an assessment that focuses on a certain area or system of the body, which is determined through the chief complaint. So how and what to assess? So you're going to inspect. You're going to look at the patient for abnormalities, things that you can see. You're going to palpate. You're going to touch or feel the patient for abnormalities. Auscultation. You're going to listen to the sounds the body makes by using a stethoscope. Another mnemonic for you, DCAP BTLS. Deformities, contusions, abrasions, punctures. Oh man, I've already forgotten BTLS. Has anybody read the chapter and remember what BTLS stands for? Who's got Google up real quick? Nobody? All right. Burns, tenderness, lacerations, and swelling. I lied. I didn't forget. So DCAT BTLS is another mnemonic to help you remember all the different things that we're looking for as we're assessing. Uh, you should always compare your findings on one side of the body to the other side of the body to see if one side is different than the other. Your secondary assessment is systematic. Your goal is to identify any hidden injuries or identify causes that you missed during your initial primary assessment. Your focused assessment is going to be performed on patients who have sustained non-significant mechanism of injury or on responsive medical patients. Your focused assessment is going to be based on your chief complaint. The goal is to focus your attention on the body part or systems that are affected by the priority problems. So, for example, if your complaint is chest pain, your focused assessment is going to be cardiac. If your chief complaint is difficulty breathing, you're going to be looking at pulmonary or the lungs. The respiratory system. So, to evaluate the respiratory system, you're going to need to expose the patient's chest. You're going to need to look for signs of an airway obstruction. You're going to need to inspect for symmetry. So you're looking to make sure that the lungs or the chest is rising and falling the same on both sides. You're going to listen to their breath sounds. You're going to measure their respiratory rate, and you're going to look for retractions and the increased work of breathing. Normal respiratory rate for an adult is 12 to 20. Children are even faster. The fastest way to do this is to count the number of breaths in a 30-second period and then double it. The respiratory rhythm, regular or irregular. So is it consistent or is it changing? The quality of their breathing. Normal breathing is silent. Normal breathing should not have any of the noises we were talking about earlier. If you hear another sound, that could indicate a significant respiratory problem. The depth of breathing. This is the amount of air the patient exchanges based on the rate of their breathing and the tidal volume. The breath sounds, uh, you can almost always hear the breath sounds better from the patient's backside. So here you can see a little diagram showing where they're listening for the breath sounds. So you're definitely going to hear them better on the backside than you would on the front. And what are you listening for? Normal breath sounds, snoring breath sounds, wheezing breath sounds, crackles, rhonchi, and stridor. These are all different sounds that you might hear in the lung. Um, for next week's class, I'm gonna get some lung sound samples that I'll play for you, so you can hear what each of these sounds like. The cardiovascular system. You're gonna look for trauma to the chest, and you're gonna listen to the breath sounds. Consider the pulse, respiratory rate, and the blood pressure, and you want to pay attention to the rate, quality, and rhythm. Consider your findings when you're assessing the skin. Compare distal pulses. So are their pulses the same on both sides of, both wrists? You can consider listening to the heart with your stethoscope to hear if you hear any abnormal heart sounds. Normal resting pulse rate for an adult is 60 to 100 beats per minute. And the younger the patient is, the faster the pulse rate is. So in the little table here, it shows all your normal ranges. That's something that's very important for you to remember. You're going to need to know this for your assessments. You're going to need to know it for your test, and you're definitely going to want to know it for your clinical time. Pulse quality. If the pulse feels like it's stronger than normal, we describe that as bounding. A pulse that's weak and difficult to feel, we would call weak or thready. The rhythm of the pulse. So if it's regular, the interval between each contraction should be the same. The pulse should occur at a consistent, regular rhythm. Or if it's irregular, the heart might have an early or a late beat, or it might miss one altogether. Blood pressure. This is the pressure of the circulating blood walls of the arteries. A drop in the patient's blood pressure could indicate a bunch of things. It could be loss of blood or fluid. It could be a loss of vascular tone and arterial constriction, or it could be a cardiac pumping problem. Decreased blood pressure is a late sign of shock. And abnormally high blood pressure may result in a rupture or other critical damage in the arterial system. A blood pressure cuff with a gauge contains the following components: a wide outer cuff, an inflatable wide bladder, a ball pump with a one-way valve, and a pressure gauge. So the most common means of measuring the blood pressure would be auscultating with a stethoscope. You can also palpate. Um, if if you're in a loud, noisy environment or something like that, you can't hear. You do have the ability to palpate as well, but it's not as accurate. Here's a table showing the normal range of blood pressure. Again, these are important things. You want to remember these. You need to know them for your test. You need to know them for your clinical time. Hypotension is a blood pressure that's lower than normal, and hypertension is a blood pressure that's higher than normal. Raise your hand if you've ever taken a blood pressure before. All right, cool. That's definitely something you'll be practicing during your clinical sessions. The neurologic system. Um, so you're going to want to assess this for any patient who has a change in mental status, a patient that might have a head injury, a patient with dizziness or drowsiness, or a patient with syncope, or a patient that's passed out. Evaluate their level of consciousness and their orientation. Use the AVPU scale. Who remembers what the AVPU scale stands for? Cyrus, go ahead.
Awake, verbal, pain, and unresponsiveness.
Very good. Another tool we can use is the Glasgow Coma Scale. So the pupil. The pupil is the black center portion of your eye. It's normally round and approximately equal in size. In the absence of light, they become fully relaxed or dilated. So you can see the pupils are constricted at the top and they're more dilated towards the bottom. And with C, you can also see they're not equal. One is larger than the other. There are patients that normally have unequal pupils. And they should know about that. They should tell you that their pupils are normally unequal. And that might be something you might just ask. If you notice that a patient has unequal pupils, you might ask them, has anyone ever told you have unequal pupils before? Some of the causes with the unequal pupils, it could be an injury to the brain or the brain stem, could be trauma, could have a stroke, could be a brain tumor, inadequate oxygenation or perfusion, or drugs or toxins. All of those things will affect the pupils. So Pearl is a useful assessment guide for the assessing the pupils. Pearl stands for pupils equal and round, regular in size, and react to light. The neurovascular status. So you want to check for bilateral muscle strength and weakness. So bilateral meaning on both sides. So you want to make sure their grip strength is the same on both sides. Is it, if it may be more weak on one side than the other, that could be a problem. That could be a sign of a stroke. Complete a thorough sensory assessment. Test for pain, sensations, and position. And then compare distal and proximal sensory and motor responses, one side versus the other. Anatomic regions of the body, the head, neck, and cervical spine. So you want to palpate the scalp and the skull. You want to check the patient's eyes. You want to check the color of the sclera, which is the white part of the eyes. Assess the patient's cheekbones. And check the patient's ears and nose for fluid. While you're palpating the scalp and the skull, you're looking for the mnemonic we talked about earlier, DCAT, BTLS, checking for all those different things, anything that might be abnormal. Checking the eyes, we just went over that. Checking the pupils, checking to make sure everything is normal. Assessing the cheekbones, you're touching to make sure that there's nothing broken in the face. Checking the patient's ears and nose for fluid. If they had a head injury, there could be fluids leaking from their nose or their ears, and that's not a normal thing. That's not a good sign. The head, the neck, and the cervical spine. So you want to check the upper and lower parts of the jaw. You want to open the patient's mouth and look for any broken or missing teeth. Why might that be important? If the teeth aren't where they're supposed to be, where might they be? Maybe in the airway? Note any unusual odors in the mouth. Maybe that's a smell of alcohol. Maybe that's fruity smelling breath, which could be a sign of a diabetic patient. The chest. Inspect, visualize, and palpate. Watch for both sides of the chest to rise and fall together with normal breathing. And look for abnormal breathing signs. The abdomen. Palpate for tenderness, rigidity, and guarding. So guarding would be the patient holding their abdomen. They're guarding it because they don't want you to touch it. That's a sign that they have abdominal pain. And remember, we have 4 quadrants to the abdomen: left upper, left lower, right upper, and right lower. And like we talked about in one of the last presentations, there's different organs in each of those areas. So knowing which organ is in which quadrant could be a clue to where their problem might lie. The pelvis. You're looking for symmetry and any obvious signs of injury, bleeding, or deformity. And then the extremities. You're looking for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate for deformities. Check for pulses, motor, and sensory functions. Have them squeeze your hands and make sure the strength is equal on both sides. Make sure they can feel you touching them on both sides. Make sure their pulses are the same on both sides. The posterior, or the backside. DCAT BTLS again. Look for symmetry and look for open wounds. Palpate the spine from the neck to the pelvis for tenderness and deformity. Assessing the patient's vital signs. Use monitoring devices. A monitoring device should never replace your comprehensive assessment of the patient. Pulse oximetry is one of the tools we use to evaluate the oxygenation effectiveness. However, one of the phrases that you'll hear often is treat the patient, not the machine. Just because their numbers look normal, if the patient is still struggling to breathe, that's a problem. You're going to need to fix that. So pulse oximetry measures the oxygen saturation of the hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. So that's what we were just talking about. Even if they're struggling to breathe, you should still give them oxygen, even if their numbers are adequate. Capnography is another tool we can use. This can provide information on the patient's ventilation, circulation, and metabolism. Capnography, there's a couple different ways we can assess it. We have a nasal cannula version that goes in the patient's nose, like a normal oxygen tube would. And then we also have a version that can go on a BVM, or could go on a King tube or an endotracheal tube. Blood glucose. You could measure the level of the glucose in their bloodstream. Non-invasive blood pressure. Your reassessment. So your reassessment is going to be performed at regular intervals during the assessment process. You're repeating the primary assessment throughout your assessment process. You're going to reassess your vital signs. You're going to compare with the baseline vital signs that you obtained during the primary assessment. So what we're saying here is you're taking multiple sets of vitals and you're looking for trends. Once you have 3 sets of vitals, you can determine, is the blood pressure going up, down, or staying relatively the same? Same with your pulse rate, same with your oxygen saturation. You can tell what all of those different things are doing, and that can tell you if your treatments are working or if you need to do something different. You're going to continually reassess the chief complaint. You're going to evaluate whether your current treatment is improving their condition. If you're treating a condition, you're looking to see if it's gotten better or worse. And has anything new come up? Any intervention you provide, you should be reassessing. Check their ABCs. Keep checking for major bleeds. Check the adequacy of any interventions you provide and consider the need for new interventions. Any changes in the patient's condition, you're going to need to identify and treat. And then you're going to want to document them. If you treat a patient and their outcome is negative or they become worse, you still need to document that. So as a general rule, our reassessments for any unstable patients are going to be every 5 minutes, and for stable patients, it's going to be every 15 minutes. All right, we made it to the review. So during the scene size up, you should routinely determine all of the following except for what? Sorry, I'm having a little technology meltdown here. All right, very good. B. You arrive at the scene of an injured person. As you exit the ambulance, you see a man laying on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. What should you do? So one of the things we'll talk about as we go through this course, the way the National Registry questions are formatted, a lot of times there's more than one answer that could be correct, and you're looking for the most correct answer. And typically, when you look at scene safety or the ABCs or the order in which you're doing your assessment, as long as you think from top to bottom, you can answer the question correctly. For example, with this question, proceed to the patient with caution, quickly assess the scene for a gun, immediately assess the patient. Those answers aren't necessarily wrong, but waiting for the scene to be safe is always your first step. So that is the most correct answer. Findings such as inadequate breathing or an altered level of consciousness should be identified in which assessment? Very good. A, primary assessment. Which of the following would you not detect while determining your initial general impression of a patient? Very good. D. So remember, with your ABCs, it's the quick, down and dirty life threats. You're not assessing pulse rates and things like that during your ABCs. You're looking for the immediate life threats to the airway, breathing, and circulation. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine and administering oxygen, you should do what? All right, we were a little split on this one. So the correct answer here is B, perform a rapid exam. So you haven't really provided any interventions yet. You're administering oxygen, but you've just begun that, so it's not time to reassess that yet. You're not going to transport yet because you haven't even assessed for life threats yet. Your focused assessment is towards the end of your secondary assessment. So the most appropriate answer here is to perform the rapid exam, where you're looking for any life threats. A semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as what? All right, good. C. Assessment of an unconscious patient's breathing begins by all right, looks like most of you went with C. So let's dissect these. Uh, remember, airway, breathing, circulation. So inserting an oral airway, you're not going to do right off the bat because you haven't determined if their breathing is adequate and things like that yet. Uh, assessing respiratory rate and depth is part of breathing. Clearing the mouth with suction is part of your airway. But before you can do that, you need to position the head. So manually positioning the head, also called opening the airway, would be your first step. That's the very first thing you would do. Your 12-year-old patient can speak only only 2 or 3 words without pausing to take a breath. He has a serious breathing problem known as. Very good. B. 2 to 3 word dyspnea. How should you determine the pulse in an unresponsive 8-year-old patient? Good. D. We always go for the carotid pulse in the neck first. And we never palpate with our thumb because our thumb actually produces its own pulse. When assessing your patient's pain, he says it started in his chest but has spread to his legs. This is an example of which part of the OPQRST mnemonic. Very good. C. Region or radiation. All right, so we've hit the end of this presentation. This was the only chapter we had for tonight. Like we talked about at the very beginning, this is the foundation of everything you're going to do as an EMT. We talked about a lot of different things tonight. We talked about, a lot of different conditions and a lot of different assessment techniques. Um, the first in-person class session you have, we're going to talk even more about all the stuff we covered today. We're going to do a lot of hands-on stuff. We're going to demonstrate a lot of the stuff we've talked about. Very important to make sure you read your book. Very important to make sure you memorize the mnemonics that we talked about today and memorize some of the different techniques we talked about today. Does anybody have any questions? Cyrus, go ahead.
On the syllabus, it says that this week was going to be chapter number 9 and next week was going to be chapter number 10. So is next week going to be chapter number 9?
I got to check with Kevin. I believe that's going to be the case.
Okay.